More has been learned about pain in the last 10 to 20 years than the previous 1,000 years. So if you haven't really updated your thinking on pain and what it is and why we and our patients are in pain, if you hadn't updated your thinking in the last 3, 4, 5 years, I promise you there's new information, which I hope that I get to teach you some of it today. So let's start with Pain Science 2018, Pain in a Nutshell, Traditional Pain Models describing tissue pathology as a source of nociceptive input directly linked with pain expression are insufficient for assessing and treating musculoskeletal pain. Let's continue in here. Other models reconceptualize pain and put forward concepts that are based on the premise that pain does not always provide a measure of the state of tissue pathology, meaning tissue damage doesn't directly mean level or severity of pain. Okay? Instead, pain is modulated by many factors. The relationship between pain and tissue becomes less predictable the longer pain persists. So how many times have you been doing an exam? I feel like my exam's pretty laser focused, especially after going through the ortho diplomat. And you still cannot quite put your finger on what's going on. And almost 100% of the times, that person is in long-term chronic pain. And that's why you can't hardly put the puzzle together sometimes, because it's been going for so long. Continuing with Pain Science. Unhelpful thoughts of patients and clinicians towards pain, including belief that pain will not get better and that movement will cause further tissue damage and worsening of the pain, are important issues to remain mindful of. I highlighted and bolded and even italicized and clinicians, because that's what we're here for. That's what we're here today to learn, how we can influence these people who are in long-term chronic pain. Purely bio is dead at this point. So what do I mean by that? So bio is, we see, there's this disc on an MRI. If we just take out that disc, they're going to be fine. Well, that hasn't worked out for surgeons very good, or patients. If we just pop this one segment, this person's going to be fine. That doesn't really tell the whole story, right? If all we're doing is focusing on the bio aspect of an injury these days, then there's a really big pile of research that says we're missing 2/3 of the equation. If the biomedical model was the correct way to look at it and was the only way to look at it, then why would low back pain now be, in 2024 and 2023 and the year before, the leading cause globally of disability? Yellow flags help us kind of start really getting into the whole biopsychosocial aspect of it. So I used to think that yellow flags were kind of boring and was just totally uninterested in them. And then I saw Annie O'Connor, who wrote a book called World of Hurt. If you are interested, it's a wonderful book, and she's an amazing speaker. Yellow flags help us as providers understand the patient a little deeper. Do they have a negative attitude that back pain is harmful or potentially severely disabling? I had a patient that came to me from another provider in Amarillo, not a chiropractor, but I believe either a surgeon or a PCP, I can't remember, but an older patient. And one of the first things I have them do is just say, bend over and touch your toes. I want to see how well they can move. And she wouldn't hardly bend over. And so I looked at her husband kind of, what the hell? And he said, well, the doctor told her that if she bends, that her spine is dry like a twig, and if she bends over too far, it's going to snap. I mean, she didn't have osteoporosis. She didn't have, so you can imagine what that does to somebody's mind, their level of pain, their fear avoidance. Fear avoidance meaning they start backing away from activities that they love because they're afraid they're going to hurt themselves. Then they have a tendency to depression, low morale. She can't even bend over and touch her toes. What's that doing to her, right? Social or financial problems, these are all yellow flags. Negative beliefs about their future or their ability to recover. How many people come into your office and they're 45 and they're sitting there going, I'm 45 and I feel like this. I felt like this for 5 years. What am I going to feel like when I'm 60 or when I'm 65, right? So words matter, and our words can help them move beyond what's been going on with them. Yellow flags delay recovery of your patients, okay? Patients who report maladaptive psychosocial factors have a significant increase in the risk of poor outcome. They don't get better like we think they should. But part of it is because they're afraid to move, because they think they never will. Two of the more frequent yellow flags are fear avoidance and kinesiophobia, or fear of movement. So let's define chronic pain a little bit. So United States National Pain Strategy defines it as chronic pain is pain that is experienced at least every other day for a period of 6 months or more. That's not the one that you usually see. The one you usually see, this really did not format very efficiently, is Johns Hopkins. Chronic pain lasts for more than any pain lasting more than 3 months, basically. Johns Hopkins goes on to say, health economists wrote in the Journal of Pain, the annual cost of chronic pain is as high as $635 billion a year, which is more than the yearly cost of cancer, heart disease, and diabetes altogether. So remember what I said. If the biomedical model explained everything all this time, we wouldn't be sitting here talking about it, would we? Also, I would say there's another form of chronic pain that I've not put in here called high impact chronic pain. And high impact chronic pain is pain that has lasted beyond 3 months, but is also associated with a disability. So those folks, you know, try to tell your insurance companies that you're contracted with this, but because they're going to look at you like you're stupid. But those folks are never going to get totally better, and they just do better if they come and see us. Everybody's different, you know, there's a lot of differences in people and treatment and all of that, but they just do better when they come see us once every couple of weeks, once every 3 weeks, once a month. They can call that wellness or maintenance, but when you're in high impact chronic pain, I think it's survival. So tissue has a healing time. So why does it continue beyond healing? So if we break a bone, we cast it, it's healed up in 6 to 8 weeks, right? Sprains, strains, they usually have a healing time. So why does pain continue into 3 months and a year and 2, 3, 4, 5, 20 years? How does that happen? Also, chronic pain is an umbrella term. And under that umbrella, they have started lumping all of this stuff. So fibromyalgia, chronic fatigue, TMJ, low back pain, irritable bowel syndrome, migraines, and potentially they think even bigger systemic stuff like autoimmune, like MS, rheumatoid, lupus, and things like that. So chronic pain is not just my back's been hurting for 5 years. It's a lot bigger deal than that. Okay, so just for a basic pain refresher, nociception is information coming in. The brain makes the decisions on how important those signals are and what they're going to do with it. We're going to let them up to the higher centers to deal with. We're going to say, like, no, those don't matter. Okay, so that's our basic understanding of nociception. But what we're not as familiar with is the term pain neuromatrix. So pain, that's basically what makes your pain experience. So the neuromatrix stores pain in the limbic system, recalls pain experiences, remembers previous injuries and threats, and it factors all of that stuff, plus a lot of other stuff, into the decision-making with regards to how bad something's going to hurt or how bad you're going to hurt from day to day. It also takes into account your beliefs about yourself. Remember, we talked about I'm 45 today, and I feel this way. What am I going to feel like when I'm 60? So your beliefs about yourself, your current health, your current abilities, and your beliefs and fears about your future abilities, those are all yellow flags. And then it takes into account what providers tell us, good and bad, optimistic and limiting, hope-inducing or fear-inducing. So these things can create yellow flags in a patient or take them away if we understand them and we know how to talk to somebody. So the neuromatrix tries to combine it all, and it alters, this is pretty important, it alters the tissue sensitivity to best match the perceived, maybe not real, but the perceived level of danger. that a patient or a person might be in. So chronic pain findings and the muddy map. What does that mean? Well, chronic low back pain patients demonstrate changes in the brain on many levels, and studies have begun to associate chronic low back pain with decreasing brain volume, which I found that very interesting. And changes in the ability to perceive the body, meaning you're having proprioceptive loss. So that's supposed to be a muddy map or a blurry map, but it looks kind of clear. Anyways, so what they say is that the adjustment is a local mechanical force, but the result has a larger global neurological effect. So how does the CNS turn mechanical inputs into sensory experience? What's different about it than all the other movements we do all day? And so basically the brain welcomes sensory inputs, which is proprioception, from all of our joints to know what's happening, where we are in space, and then in turn construct the best response, resulting in hopefully functional movement. So let's talk about sensory motor.